All right, it is 10:01 and we will go ahead and get started. Welcome everybody to the second of this year's Change in Action webinar series on interoperability as in last year in April, continuing to remove barriers to value-based success, or are we talking to one another yet? On behalf of the BREE Collaborative at the Foundation for Healthcare Quality and the Washington Health Alliance, I am grateful for all of you in our audience and to all of our speakers for joining us today and really bringing this intention to help improve our healthcare ecosystem. I am Ginny Weir. I am the CEO of the Foundation for Healthcare Quality. I am joined by Nick Locke at the Foundation and our fabulous partner, the Washington Health Alliance, with Dr. Sharon L. Aranta and Denise Giambalvo. And just a pause for housekeeping. You're all on mute and will be throughout the day. Please write any content questions in our Q&A box, which should pop up below on your screen, and any technical issues into the chat box. We will be monitoring both throughout this webinar. And additionally, this webinar is being recorded and the recording will be posted to our YouTube channel and also sent out along with our slides. Although I am the only one using slides, it's a little bit of a crutch, but I find great joy in making PowerPoint slides. So forgive me that. So why are we all here today? We are here because our two organizations really want to help accelerate our healthcare delivery system's transition from the fee-for-service space to value-based care. I'm borrowing these two images from the Healthcare Authority's value-based care roadmap, mostly because I love these little avatars. So fee-for-service, you'll see here, is when a healthcare provider is paid for each service, regardless of the quality of that service. You can see the leg being still broken. And value-based care, when a provider or system is paid for providing high quality and high value care to a person or a population. So value in healthcare is the measured improvement in a person's health outcomes for the cost of achieving that improvement. And look how happy our little avatar is now that their leg is not broken. They have received high quality care. And Washington State aligns with the definitions created by the Centers for Medicare and Medicaid Services. These four categories with which most of you are probably overly familiar that move from fee-for-service with no link to quality or value to a population-based payment. And so the standard of what we consider value-based payment is indicated in blue. And so we know what value is, but how do we get there? What are our ingredients? And so our team at the foundation wanted to know, why isn't this happening already? And looked again to the Healthcare Authority. They have conducted surveys of both payers and providers over the years. And here you can see the top 5 enablers and barriers for both groups. You'll see interoperability as a top barrier, really the top for payers and enabler for both of these, along with features like aligned quality measures, aligned incentives, and trusted partnerships. So our team developed our ingredients for value-based payment: social determinants, interoperability, aligned quality measurement, and multi-payer strategy. These became our accelerators for change in 2021, and we challenged our community to take one meaningful step last year, and again, offer this same challenge to all of you today. So we shift from our framework for action in 2021 to our change in action through this year with a similar 4-part webinar series across our 4 topics. A year ago in April, we asked, why don't we talk to each other? And today we are asking all of you and our speakers, are we talking to one another yet? Our learning objectives today are really to get everybody on the same page and then move forward as a collective. We hope to create a shared understanding of interoperability and why it is important to value-based success, orient thinking towards being patient-centric rather than organizational-centric when we're talking about solutions, identify pathways to success on which we can all agree, and then describe how everybody contributes to meaningful change, how providers, health plans, purchasers, and even patients can realistically help to achieve in our state. So let's meet that first objective early. What do we mean when we say interoperability? We are going to use the Healthcare Information and Management System Society definition, the ability of health information systems to work together within and across organizational boundaries in order to advance the effective delivery of healthcare for individuals and for populations. Now, this is a quote from an article that we've been sending around in our circles that we found very inspiring from David Lansky, former CEO of the Purchaser Business Group on Health. He recently published this article, Reimagining a Quality Information System for U.S. Healthcare, that was published in Health Affairs, and really argues that it's time for a wholesale replacement of our system for measuring healthcare quality and putting quality information to use. That our current retrospective transactional system for measuring and rewarding improvement is ineffective, expensive, burdensome, no longer credible, and does not measure health or the outcomes of healthcare. And really that we need profound changes in how we capture and apply information about quality of care and about health outcomes. Or, as the American band asked in 1992, what is going on that we don't necessarily know what's going on, but that we can? And so Dr. Lansky says that what we need is a national data infrastructure that operates independent of practice setting, aligned multi-payer incentives that support needed infrastructure improvements, longitudinal patient-reported outcomes captured in delivery systems and through mobile technologies, robust regional demonstration projects to broaden that stakeholder understanding, and a governance mechanism that ensures simplification and alignment of methods. So how close are we to this? How much are we able to rely on regulation and our existing infrastructure, such as information blocking, to help achieve this interoperable data system? And so for those unfamiliar with the parenting technique of using a get along short for siblings, I would say the evidence is probably mixed, but something that I'm going to keep in my back pocket as the mother of two girls. And so our goal today really is to help foster a sense of trust between our healthcare sectors. Again and again, trust is highlighted as the most important aspect to data sharing. A recent article from the National Academy of Medicine reiterated this importance of trust when looking at cultural, ethical, regulatory, and financial barriers to data sharing, linkage, and use. Lack of trust is the barrier identified by all the groups, by healthcare executives, research leaders, patient and family leaders. And I'll acknowledge an author of this paper, Sarah Green, who is also a board member of the Washington Health Alliance. It's a paper that I encourage everyone to read, as it really helps get everybody on that same page. And so trust, the space between sectors, the space of building trust, is really where the Foundation for Healthcare Quality and the Washington Health Alliance shine. We are both neutral organizations that are really able to solicit this engagement from the multitude of healthcare sectors for whom we work. A quote from Frank Sonnenberg: trust is like blood pressure. It's silent, it's vital to good health, and if abused, it can be deadly. And this theme of communication and trust will come through all of our speakers. Dr. Jan Berger from Health Intelligence Partners, Vishal Chaudhry and Kathy Ott with the Washington Health Authority, and then our panel discussion with Rick Rubin of One Healthport, Dr. Marla McLaughlin with Vero Whole Health, and Sashki with Jane with the Primera Blue Cross. And so now it is my pleasure to turn over our virtual stage, once I stop sharing these slides, to Jan Berger. Dr. Berger is president and CEO of Health Intelligence Partners, a healthcare consultancy that she founded in Chicago, working with clients globally on healthcare business strategies and business development. She has worked in healthcare administration, within health plan and academic areas, leading operations for 2 population health companies, and as senior vice president and chief clinical officer for CVS Caremark. She received her MD and her JD from Loyola University in Chicago, sits on multiple boards, has authored several books, and serves on editorial boards for a number of healthcare journals. Thank you so much for joining us today, and I will turn our stage to you.
Thank you so much, Ginny. And the truth is that the talk you just gave, you do not need me to speak at all. I think we are so aligned without us talking really in depth before this. It's amazing. But let me just go into a little bit of more depth in a couple of places. I presently am at a national conference with C-suite executives across the stakeholder environment in healthcare. And so I did a listening tour in preparation for this conversation today and asked them, what role does interoperability play in achieving value-based care? And what was so interesting is I got a wide variety of response to that question. And as I dug a little deeper, as I am used to doing when I don't understand necessarily what people are saying or why they're answering it, I found out a number of things. And that's where I'm going to concentrate my 10 to 15 minutes. When I was asked my own opinion of in preparing for this and asking if I would talk with you all about my feeling about the relationship between interoperability and value-based care, and was it necessary? I used the analogy of how many of us have ever driven a car using just the rear view mirror. I think if we were in a room together and I asked you to raise your hands, probably, except for in backing up, that doesn't count. But in driving forward and moving forward, how many use only the rear view mirror? Hopefully nobody would say yes. But I would argue, after being a primary care physician, an academic executive, and then executive across all the stakeholder groups in healthcare and representing employers, that none of us want to be rudderless in moving forward with value-based care. It's just not how we're going to get to success. Ginny's initial question about, are we talking to one another yet? I will applaud this group because you are talking, and many of the things I'm going to spend a moment talking about are things, as I said, Ginny has already spoken about, that you all have taken a stand on. Yes, there are organizations that come to conferences like Health Evolution Summit, where I am at, that are having conversations, but we are in the first or second inning of those conversations. We really are. Is there an intersection? I think we would all agree there is an intersection. Some don't agree that is necessary, but when I asked them about why they felt it was not necessary, what I found was there were differences in definitions. So as you all taught, as Ginny showed those slides about that you all have agreed to definitions, that's great. Make sure everybody at the table or everybody who is impacted either understands what the definition is or has a say in that definition. Because we do know from the research in re-engaging in trust, definitional differences or lack of clarity is a negative trust reset. And there are 15 trust resets when you look across what can either positively or negatively impact trust. And speaking the same language, if you will, or definitions, is one of those areas. So I want to take a moment and talk about definitions. The term interoperability is not understood in the same way by all the stakeholders or a variety of individuals within the stakeholder groups. So what kind of data? How is it collected? How is it used? The timeliness. Who is it going to be passed to? All of those things, as part of the definition of interoperability, have to be played out. One of the people who is a significant player in healthcare in the United States said to me, its interoperability is not an imperative for value-based. But when I asked them, they said, claims data is dirty. It's retrospective. So why are we going to use that and say that is what's necessary for value-based care? So that person had a very narrow viewpoint, in my opinion, of what interoperability is. So it's very important, in order to gain the trust, in order to move forward, the definition of interoperability of everybody has to be aligned. A second area, and Denise, I apologize, you've heard me speak about this a great deal of times, and that is in value-based care, defining value to whom and what is value. We are still arguing as a country as to what is quality. And if you use things such as NCQA or other national organizations that have defined quality, we still argue about it. And those things started in the late 80s. I was the first health plan in the country. I was a test health plan to go through HEDIS and NCQA early. It's still being argued, partly because it depends on who you are and how the value is attributed. Healthcare in the United States is often paid for by one group, but the value being at least partially attributed to another group. So sitting down and saying value to whom, are the goals aligned and aligned incentives, is another trust reset that has to be delivered. You can't ask people to do something that is going to hurt them and expect them to do it, to change a behavior or to open up. Altruism is fine, but you'll also hear many people say no money, no mission. So it's very important that there is agreement and definition of value. I will tell you at Health Evolution, there are all kinds of definitions of value. There is not agreement at a national level. There may be in your all's work. And again, I would applaud you, but I will tell you nationally, it continues to be an issue. Another reason that I would say that that interoperability is very important. We all are challenged by engagement of the providers, engagement of the patients, members, consumers, individuals, whatever you want to call them. And one of the things that interoperability, if done well, allows for is timely personalization. We are all bombarded. Take us before COVID, take us before the war. The country has PTSD, and we know that. We know that in workforces, we know that in individuals. And it's been well documented. But we've all been overwhelmed by all kinds of information. So personalization allows for relevance, for specificity, and for proactivity. So I would argue, if done right, one of the greatest challenges we have in value-based care, which is engagement of the important parties, is achieved through interoperability. We do know that, and finishing up, interoperability in conjunction with value-based care is a multi-stakeholder issue. It's a team sport. It can't just be one person. I would argue it is absolutely necessary and an imperative to truly achieving value-based care. Dr. David Shulkin, who has run health systems and twice has been the head of the VA, both under Obama and under President Trump, talked about the fact this morning that although we are in the earlier stages of value-based care, we are in a race against the clock now. It is not something we can do slowly and methodically over the next number of years. We're starting to see government pricing models and other things that could negatively impact value-based care, or to get to the end goal of cost, not cost, quality, and humanistic and access, but cost. And that can hurt our goals of true value-based care. The one other thing I want to say, and Ginny, you had a slide on this, data has been used as power and a currency historically. Lack of willingness to share. People making money over data and therefore not wanting to use it for outcomes and quality and value, but for profit. And please don't get me wrong. I work in commercial businesses. Profit is necessary to survive. But these are things that cannot be used against us. They have to be used for us. I'm not saying all of this is easy, but I will say we have the tools and the capabilities today to do it. We need to have the desire. And the desire is going to come from one of two places, either regulatory, because they have to be at the table. An example of the electronic health records, how did we finally get there? Through regulatory pathways and through payers. The employers, the government are the major payers in healthcare today. The individual consumer is also increasingly a payer, but they get the outcome. They often are not a stakeholder that are going to have to push today to move forward with interoperability and value-based care. But both of those groups are required. So the thing I would do that I always do as I end my statements, comments, is to give everybody an assignment. So I would ask, and some of this it sounds like you've already done, but please make sure the starting assignment is making sure your definitions of what is interoperability and get specific. And what is value-based care? How do you define it? On the number of boards, I sit on 5 boards internationally, and it is fascinating, even in the boardroom, we don't always all agree on what is the definition of value-based care. So if you do nothing else, come out of today's conversation with a very concrete to-do and the timeline in which you're going to do it. Thank you for inviting me. And I hope my thoughts provoked some thoughts for you all. Have a good day.
Hi, my name is Sharon Eloranta, and I want to thank Jan for that very inspiring talk. I feel like we, just barely started to hear from you, and hope we get a chance to do so again now. That's just wonderful. So, and I think you also offered us a really nice segue into our next section of this, which is that we will hear from 2 representatives from the Washington State Healthcare Authority. And as Jan just said, governments tend to be large purchasers of healthcare, and the Washington State Healthcare Authority certainly is the purchaser of the plurality. About 1/3, I guess, of the state's residents are covered by programs under the Healthcare Authority. And so it's imperative for us to understand where you stand with regard to interoperability and value-based purchasing. So very quickly, because I know we want to hear more from you than from me, I will give you little introductions. We have here today Kathy Ott. who is the Information Technology Strategic Advisor for the Healthcare Authority. And in that role, Kathy partners across the Healthcare Authority and the Washington State Health and Human Services Coalition to help define and shape the technology vision and align with strategic objectives. She has extensive experience in the state's Medicaid Management Information System, analysis, design, implementation, program integrity, and enterprise and data analytics. Also excited to welcome back again, Dr. Vishal Chaudhry, who actually trained as a mechanical engineer, which I find super interesting. He serves as the Washington State Healthcare Authority's Chief Data Officer, overseeing how the Healthcare Authority prioritizes, maintains, and applies data and information to support agency goals and processes. He has 20 years of implementing and improving business processes across the healthcare, electronics, and automotive industries. So with that said, because we want to kind of dive right in, we know we heard from you last year on a similar topic and wondered if each of you might take a moment or so to kind of talk about what has changed. I know it's a pandemic year, so it was odd, but kind of what do you see were advances and or specific challenges that were faced in the past year, both on the topics of value-based payments and interoperability? So maybe Kathy, do you want to start?
Sure, be glad to start. And thank you for inviting us back. It's a interesting question to say, are we talking to one another yet? And I'm going to touch a little bit on that in kind of my thoughts about where we are. Interoperability to me, of course, is one of the most complex and the challenging imperatives for healthcare. And I do believe it is an imperative. And when we look across the industry and we think about the technology investments that are being made, the reading that I do, healthcare CIOs are really investing in interoperability, AI, machine learning, telehealth, security, but interoperability is on the list of just about every healthcare, both on the payer side and the provider side, really reinforcing to me the fact that it really is an imperative for us. And when I look over the last year, what we've kind of accomplished, there are a number of things. We have done a lot of advancement in EHRs and implementation as the foundation for data sharing, and really looking at how EHRs are used and can be interoperable both within organizations and across. Lots of conversation about standards, and if you're on the technology side, the APIs that go along with that and standardizing the way that we share data. Patient identifiers flow into that as well. So there's been some work that we've been doing here at Healthcare Authority to allow us to identify a patient across systems. And when I think about the question, are we talking to one another yet? It'll be interesting for me to maybe come back next year and say, are we hearing each other yet? Because to me, we can dump data. There's been some advances in technology that allow us to exchange data. I'm not sure how much we are using those data yet. So once the data is out in the community, in the provider community, are they able to interpret that data and actually use those data in their workflows and for the outcomes on the value-based payment side that really translate into quality benefit for clients, cost containment, those kinds of things. So to me, that's one of the questions we've made. Some real advancement, I think, on the technology side. We can share data probably better than we did a year ago. Lots of investments there. But I think the ability to actually use data, which to me is kind of the highest level of interoperability, and where information systems can exchange, but they can really decode that data and they can make it usable for providers and for clients. So when I think about the future and really talking to each other, I kind of I put it into a couple of categories. One is what I just spoke about, which is really moving beyond data sharing to, meaningful, consumable data. And we've moved, I think, from a period of how do I get more data into the question of how do I turn these data into, information and insight. And I think that's a shift that we're seeing. It's taken some time to get there, but the capacity itself to share data is not enough to deliver on, the promise of interoperability. It's not enough to, meet the needs of value-based care. So that's one area. And then the other is really focusing on putting the data into the hands of the patient, the consumer, and how we do that. And really looking at equity and those things as we build out health literacy for clients and those kinds of things. So that, and the fact that healthcare is, increasingly shifting from institutional care settings to home settings, and we need to build out interoperability into the community as well. Many of the large EHR systems that connect the payers, connect hospitals, connect providers, don't yet go out into the community. So I think there's some work to be done there as well for the connection and interoperability that speaks across the community setting. So I'll stop with those kind of high level remarks and let Vishal take this up, and we'll go from there.
Great, thanks.
Thank you, Kathy. Again, thank you to the foundation for inviting us back. It's fun when you go somewhere the first time. It almost feels like a fluke. When you're there a second time, it's like, oh my gosh, they really want something from me now. But I don't know how much to add on what Kathy said and what Jan mentioned. Something that struck with me is Jan's analogy of driving while looking in the rearview mirror. I'll take it maybe a step further in terms of how we approach not just interoperability or data exchange, but also the way we provide care in our healthcare system would be, to use that car analogy again, it's like looking at the dashboard to drive the car forward without looking through the windscreen to see what's in front of us. It's almost like we're relying too much on just the data of what's happening right now and trust that it'll take us to where we think we need to go without being clear on where exactly we're headed. Not just from a care delivery standpoint, but also from a system design standpoint. And some of it is a function of where we've been. It's been a disjointed data world in the healthcare space for such a long time that Jenny, I love that the get together shirt or get along shirt. That's what it feels we have been doing, right? Through regulatory levers, through payment levers, call them incentives or disincentives, pushing, cajoling, coercing players to kind of come together and at least be in the same room and start talking to each other. I think as a system, we need to evolve to the point where we're actually putting the path forward so we can look through the windshield and say, this is where we're headed. This is where we need to go. And yes, we all need to be in the same car in order to get there, but just by being in the same car and looking at the dashboard in and of itself is not going to get us there. Sorry, I think I've belabored that analogy. So getting back to, where we've been over the past year, like Kathy mentioned, a lot of investment has been made. What we have learned, and there's a good and bad to the pandemic. I'll focus on the good for a moment. It has surfaced a lot of the underlying disjointedness of the system that everybody kind of sort of knew that it existed, but it brought it to the fore like never before. We could really see, yes, the Department of Health gets data from the hospitals on a regular basis, but nobody's able to use it. So they had to work to develop a completely new system to make it usable. It goes to Kathy's point. Yeah, there's data being exchanged all over the place, is it usable? Are we able to actually do something with it, right? Similarly, talking about claims data, like Jan's mentioned, right? Claims data is dirty. Well, there is no such thing as a perfect data set. It doesn't exist, right? Even financial data sets are dirty. If you ask the financial system folks, there are issues that they need to resolve, and it's money. We better be good in that. But what do we need to do? Like, what else do we need? There's no one silver bullet in this, and interoperability, it is an imperative, and it is a systemic imperative. Like I often hear executives actually talk about interoperability as an initiative. I'm sorry to say this, it's naive, right? It's a way of doing business, and we're barely starting on that journey. So managing our own expectations is to say, okay, setting up databases and making sure people are using the same definitions for data elements and using the same standards is a good first step. Having tools like APIs that can actually perform in a much more nimble manner than we have been doing in the past is a good one step. None of those are silver bullets or solutions, right? What else do we need to do? How do we need to invest in? Kathy talked about the usability of data, right? And the workflows. And I heard PTSD about the system. I've been analyzing the healthcare system for the last 15 years. And even before COVID, we had a lot of challenges that have existed in our system for a long time. They just became more visible through the pandemic. We still need to solve for them. And part of that is the overall delivery system capacity. In another conversation, we're talking about high-level analytics and insights. Well, yes, we can produce, and right now there's a plethora of good healthcare information being produced, analysis being produced, lots of think tanks, lots of analysis happening, lots of research happening, good information out there, much more so than probably a decade ago. Is the delivery system capable, or does it have the capacity to use that information to make the changes, right? We have a delivery system that's already burdened, not just from a provider caregiver standpoint, but also the way the system is designed. All of the people like me who don't really provide care, who support the system, how do we evolve that system? How do we support it so that we can then leverage the technological advancements and the work that we do in the interoperability space to make the changes and to actually have an impact, whether it's in the value-based care space or whether it's in overall quality of care and some of the broader public health metrics. So I'll stop there and see.
It sounds like we only have like 5 or 6 more minutes, and I have a couple of different directions I'd love to go, a whole bunch of them. One of which was to try and talk a little bit more about, figure out where we're going and where we're going to get that road from. But I feel like we do need to, I'll just make the choice and try and expand a little bit about the implications of health equity when we're talking about these types of technological and other advances. Can you say anything about like how interoperability, value-based, payment arrangements, that sort of thing, intersect or don't with interoperability and availability of language, and how you use it? As you said, you can have it. If you can't use it, it's useless. Just a few minutes from each of you on that.
Sure, I have a few thoughts on that, and it really, and when you put this at the intersection of interoperability and value-based care, you're really talking about, coordinated care with a patient-centric focus. So then we need to start thinking about, how those things fit with equity and what we can do there. And I think that some of the important innovations that we haven't focused on yet have to do with increased, digital literacy, accessibility for all populations, addressing those things like language, technology, literacy, those kinds of things. And we need a combination of training and education and support, technical innovations that make technology and health records every day. We're a long way from that. And I think this hits our most vulnerable populations, and some of the focus that we have on equity, I think that hits those populations even more from the perspective of not having the data, the innovations available to them. So I think there's a lot of work that we need to do there. A lot of recognition and training and focusing on different populations. I was smiling just a bit when Dr. Berger was talking about the definitions. We are working on community information exchange here at Healthcare Authority and across the Health and Human Services Coalition. And when we started out the work group across the coalition, I think we spent 6 or 8 hours of meetings trying to define what a CIE was. Everybody had a very different definition of what a community information exchange was, and they all focused on a very specific population and set of things that fit into the whole equity lens as well. So it was just interesting for me to hear. I think that's one way that we look at it, is looking at what that looks like when we start to drive interoperability out across the community and see what the community population is and what their needs are. So.
Just additional comments on this topic, Vishal, or do you want to go a different direction? It's fine.
No, I think, Kathy, I not a whole lot to add to what Kathy said. I'll just say, from, especially when we talk about care coordination, right? So interoperable systems to facilitate care delivery and care coordination work that would eventually help with value-based purchasing arrangements, whole person care, all that stuff, right? And this is something that all organizations deal with in some way, shape, or form. You can classify data in general in 3 different broad buckets, right? There's retrospective data. What happened yesterday, last year, last 10 years? It helps us understand the trends, helps us do research, helps inform strategy, policy. Very good and very meaningful information. It doesn't help me do what I need to do today to make decisions, right? That's operational data. What's happening today? What happened yesterday? Do I need to make any course corrections? Just core operational information that those who are actually performing the work, delivering the care, they need access to that information. The third is what I would call true real time. And that's the looking through the windshield piece. That's the care coordination piece. When there's a patient presented to a provider, or a patient presents themselves to a provider, does the provider have the information to be able to help the patient in the way the patient needs, right? And that is, so these 3 different needs have to be approached in a way that one solution or one set of solutions may not be able to meet all these needs, right? And interoperability, when we talk about interoperability, which part of the need are we trying to solve first, right? So that's a conversation that I think is ongoing. I just wanted to add that.
This is fantastic. I think you can remain assured that you will be invited back again. This is such rich conversation, and even in our prep talk, I learned so very much. So I do want to thank you both for this great input. You've given us a lot to think about, and want to go ahead and hand this over to my colleague Denise Giambalvo here at the Alliance for our next panel presentation.
Thank you, Sharon. Thank you, Vishal and Kathy also. So yes, we're moving into our next discussion, and we have Sakshi Jain with us. She's the manager of strategic provider programs at Premera Blue Cross, and leads several transformational initiatives designed to make healthcare work better, including interoperability and transparency and coverage. Sakshi's work aims to provide systemic solutions to solve legacy healthcare issues through reimagined provider partnerships and collaborations. Sakshi holds a Master's of Health Administration degree from the University of Washington and a Master of Business Administration and Bachelor of Pharmacy from her education in India. Marla McLaughlin is here with us. She's a family medicine physician and currently the Associate Chief Medical Officer at Vera Whole Health. She started her career in a traditional fee-for-service medical model for 3 years. Acknowledging the need and desire to focus on the quality rather than the quantity of care, she entered an employer-based advanced primary care model for the last 3 years. Initially in the Kansas City region, then as regional medical director, recently moving into her current position. She is currently spending a lot of time working on the interoperability of a project in Columbus, Ohio, with JP Morgan, Central Ohio Primary Care, and Vera Whole Health. We're happy to have you here with us, Marla. And then finally, last but not least, Rick Rubin, he's Chief Executive Officer for One Health Port, the health information technology management, working to solve information exchange and workflow problems shared across healthcare organizations and as the lead organization in Washington State for administrative simplification and health information exchange. Rick also currently serves as the executive director of the Washington Healthcare Forum, a coalition of senior executives who work to improve Washington State's healthcare system. Rick has served in a variety of former roles in various healthcare sectors, is actively involved in the community on public and private boards, and teaches in the School of Public Health at the University of Washington. So happy to have such a fabulous panel here with us today. My first question for you is, can you speak briefly about your experience with value-based payment models? What's working, what's not working, and particularly regarding the interface with interoperability? And I will ask Marla to kick us off that question.
Sure, thanks, Denise. I have, spent most of my focus on probably 2 of the main value-based care structures, and that being shared risk in both savings and loss. We've had those structures with some employers, we've had those structures with some payers, and we are moving now more towards full capitation. So our big project I was kind of talking about with the interoperability in Columbus, Ohio, the client there are the 32,000 patients that have JP Morgan insurance. They're insured that way. So we have joined with Central Ohio Primary Care, which is a group of 400 providers that already have a lot of value-based contracts with payers. And they also work with Agilon doing all of the Medicare Advantage, all of that value-based stuff. So they have been in that space for a while. We're actually creating a risk-based entity, an RBE, we call it a risk-based entity between COPC and Vera Whole Health. And we're going to take global risk and full capitation on that JP Morgan population. That, of course, is not something you do from day one. We kind of have a glide path over the next 1.5 to 2 years. So even to that extreme, that's a new thing for us, that value-based payment model, but we truly believe that that's the direction it should move. So as far as what is working, I mean, value-based care in general, I think we all agree is a better way to deliver care, and it aligns financial incentives. As far as what's working with interoperability specifically, I feel like we see moves in the right direction. But it is true that taking global risk on a population, we really need the perspective and not the retrospective. And we need the perspective analytics to look at this whole population that we're taking care of. I mean, if they come to us, that's great. And of course, that's what we want. But a lot of them won't. And we know that. And we're still taking risk on their care. So it has to be a true coordination. So I would say what's not working is that we've used so many time resources to literally build our own data warehouse between us and COPC. So anything that happens at one or the other, it's kind of sitting in a place that the other one can pull it. And I realize these aren't new concepts, but we've had to build it for ourselves for this to work. And there are some other very large health plans in that area that we're literally probably going to try to contract with to say, you're also seeing some of these people. How do we all talk and how does it benefit everybody, and keep it patient-centered? So that was a long answer. We have also merged recently with Castlight, which is an IT company that does perspective analytics they use ICD-10 codes, DRGs, they use claims, and try to really determine what a population is before you start taking global risk. And so we're hoping that in combination with our approach to care is going to be really helpful towards really pushing this continuum of value-based care.
Great, thank you. Sakshi.
Hi, hello everybody. So we here at Premera, we've been working over the last couple of years to meet the requirements of the mandate. And in doing so, we've built the infrastructure that we can now begin to leverage and advance value-based care. In having made those investments in the space of interoperability and the interoperability mandates, and working very closely with some of our key and strategic provider groups in adopting the Da Vinci standards, for example, exchanging member roster information with the goal to smooth workflows, reduce unnecessary churn, prevent data stagnation. With all of that, with access to this timely information, be it provider encounter or claim information, now that information can now flow through our systems and also provide real-time information on that, the performance of our value-based contract. So having said all of that, I think the one thing that has worked well is, and I think Marla mentioned that too, is the member centricity, almost, because that creates the melting pot for all the stakeholders involved in this to come together and drive towards the same end goal. And the other thing to call out is, I think the implementation of the interoperability rules and the patient access rule that has now started to provide that same common language, thereby making the solutions that we're putting in place today scalable, and also the application of those solutions from one to many, creating those economies of scale. So those are the things that I think have worked well as we've tried to sort of make advances on that value-based payment models. The one thing I think, while I say that this is not working well, is the financial upfront cost of really investing in the space of creating those interoperable pathways and channels, which I think is a big barrier, so to say, to be able to really think through strategies that talk about our entire network of providers being interoperable with each other, etc. So with that, I really think this is glass half full. So there are opportunities that we're continuing to work through, and we've made significant advances in working with our the key provider groups who have the bandwidth and the capacity to work in coordination with us in that space locally here in the state of Washington.
Thank you. Rick.
Yeah, thanks. Good morning, everyone. I come at this from a slightly different perspective in that we are not delivering care or insuring members. We have a great privilege of sitting in the middle as an intermediary, trying to help people who are trying to solve problems, often around information, not exclusively. And so it's interesting to talk to folks and get their insights. I'll come from a slightly different perspective, maybe. One, I think interoperability is an awful word. I think the fact that we use a word like that speaks volumes about why we have problems. It's not a word that any normal human being would ever use to describe the exchange of anything. Have you ever talked about hoping that Coldplay and Spotify and AT&T and Apple could interoperate so you could listen to your music? You would never say that. So one observation I'll make is I think the word is a huge distraction. We will never be interoperable, and we will never be not interoperable. Interoperability is a continuum. It refers to, the ability to exchange information. There are certain aspects of healthcare where we can exchange lots of information, drugs, medication. There's a lot of good public health stuff being exchanged in the state, claims data. And then there are other areas where we've really barely begun. And so I think it is really important to think less about that global question, because frankly, in today's world, a lot of the global decisions about interoperability are going to happen elsewhere. They're going to happen nationally. And if you look at sort of the systematic stuff that we need to exchange information, we need standards. We've made a lot of progress on that. There's still work to go. We've deployed networks. You know, we operate an HIE in this state. You're starting to see a lot more things going through the national networks. It's already been talked about the importance of applications. You know, you plug into a network, you use your phone, your computer. There's certainly a greater prevalence of those. There's been regulations. Some people like those, some people don't, but I think they've certainly had an effect. There's capital being invested. $30 billion was put into the digital health industry last year. I think one systematic piece that is missing, that was referenced early in this conversation, is trust. I think we have done a lousy job in general about creating the necessary elements of trust. And I think this bears on the question of individuals. I think in general, we as the health industry tend to want healthcare consumers to meet our needs. And we tend to share information and create systems built around that. And we don't spend quite as much time figuring out how we're going to enable consumers to get answers to the questions they want. I think, my last sort of global comment is, are we talking to each other? My observation is we talk endlessly to each other, specifically in the Pacific Northwest. We have endless conversations. I don't think the lack of conversations is the problem. I think we have some great organizations that facilitate conversations. I think the problem is we're not talking about the right things. And I think we need to move from, a concept like interoperability to a much more specific conversation about what problem are we trying to solve. My experience in collaborative activities is when you're all agreed on what problem you're trying to solve, things go better than when you're not. And I think that's where the opportunity lies. I will make the bold statement that while we have a lot of work to do on exchanging information, there's enough basic capability in place to do a lot of things. I think the opportunity for us, and I go back to Ginny's comment about Dr. Lansky's paper and that little bullet about regional pilots. I think it'd be wonderful, instead of sort of saying that the barrier to value-based care is a lack of interoperability, instead say, well, what is it we want to do? What specifically do we want to do as a community to use all these capabilities that are out there to advance value-based care? I think if we had that kind of conversation, we could make a lot of progress.
Excellent point. Thank you. And you're all welcome to share what you think that pilot should look like in the chat box. So how do you anticipate the FAST healthcare interoperability resources standards and CMS mandates will affect the move to value-based payment systems? Who would like to take that?
I'll share an observation. I think information blocking is fascinating. We don't know what impact that is going to have. There have been a lot of comments in the chat and throughout these conversations about a lack of aligned incentives. I may have the technical capability to share information, but I don't want to, because I view you as my competitor, or I don't have the same interest in you. In theory, information blocking could change that. It's brand new. We don't know how the industry is going to deal with that. We don't know whether everybody's going to fight it tooth and nail. We don't know how it's going to be interpreted and enforced. But I think that is one piece that is sitting there that has lots of interesting potential. There's this, speaking of bizarre terms, there's TEFCA, which is another federal reg, which again, no one understands. But the hope there is that will do two things. Number one, that will help the existing networks talk to each other more expeditiously, which is an important part of information sharing. But number two, a lot of the focus on information sharing has been around individual patients being treated by individual providers. That's where the efforts have been made. And there's this little thing coming up, FHIR, again, another bizarre term, which is just sort of healthcare APIs, application programming interfaces, how two software programs talk to each other. There's a bulk FHIR query that is, in theory, supposed to be useful by regulation for all electronic health records by the end of this year. And it's pretty interesting to think of the what we could do on a population health basis as a community, as a state, to solve problems. And Denise, if you're looking for a candidate, how about maternity care? A lot of reasons for that one. That we could use some of those type of tools. You know, you marry bulk FHIR queries with information blocking, with the prevalence of networks, with some of the organizational infrastructure of the Alliance, the Foundation, BRIE, and so on. Maybe we could take a whack at beginning to build David Lansky's dream and have one of those regional pilots.
Great. Thank you, Rick. Sakshi or Marla, would either of you like to respond to that question?
So
Oh, go ahead. Go ahead.
go for it,
Sakshi.
Mala. I'll hold my thoughts here.
I don't have a lot to add. I would say about FHIR, the way I feel about that is it's a step in the right direction towards value-based care. I don't think it's a huge step. I think it's a pretty small step, but anything that moves, I mean, ultimately, for everybody to be truly invested in us all being on the same playing field and all having all the information, we need to move faster to value-based care. So anything that can move us faster to value-based care and get people on board, I think ultimately is going to serve the goal of keeping this patient-centered. And the bottom line is, it will be lovely when we get to a world where success actually means you're taking better care of the patients, and simply means that and that alone. And for us to make that the only variable is how well you're taking care of people. We all have to be on the same playing field. So I don't want to knock things like FHIR because I think it's great. I think it's a small step in the right direction of more value-based care.
Sakshi, anything additional?
I would just build on that. I also believe it's the step in the right direction. I think it is creating new proving grounds to finally break through decades of information sharing obstacles that have long impeded the transition from fee-for-service to value-based models. And the one thing that I want to add is, when I think about the critical role that technology can play in our greater healthcare landscape, I consider its potential to exchange and effectively use that electronic health information in a timely and meaningful manner. And I think the question at this point is, how should we best approach this pivotal task of integrating the two healthcare transformations that are happening in parallel, which is movement towards these common standards, this common language for the different stakeholders in this ecosystem to operate with, but then also moving to value-based care. So,
Thank you. And so Sakshi, I'll stay with you, and I'll just ask you, what does Premera need from the data infrastructure?
So what we need and would be successful would be the wide adoption of the standards from the data infrastructure, and for the data infrastructure itself to continue to evolve and become more sophisticated over time. Because, for example, right now we're talking about building that longitudinal health record. I think over time, we would like the conversation to mature to actually adding depth to that longitudinal record, so that we're just not talking about stitching those different pieces of information together, but actually contextualizing that information in a way that it is helpful at the point of care to the provider who is serving our members. And the other thing is, how do we ensure that the data security protocols are top of mind as this data infrastructure is more widely adopted across the industry? And the implementation guides itself that are helping sort of bring these use cases to light today, be it to alleviate provider burden, burnout, reduce redundancy and duplication of care, bend total cost curve. How do they mature and how are they adopted over time by the many different stakeholders that are involved in this total journey? So, and the one thing that I think we lead with that, the work that we're doing here is to make it easier for providers to provide care to our members, because we truly believe that provider care is part of patient care. So for that data infrastructure to really support that end goal is what we need from this infrastructure.
Thank you. Marla, so Vera Whole Health, you've already said you've invested quite a bit of money in creating an infrastructure. What do you need?
for the kind of work we're doing, especially with these full capitation models, we need this to move to more proactive than reactive. The whole key to global risk, we have different programs, and knowing where to put our different programs in place by knowing the population before we ever walk in the door is super, super important. So if we have a population that really needs behavioral health, or do we have a population that really needs some on-site musculoskeletal? Do we have a population that would be more affected by some pharmacy, fixes and solves? And so we kind of have this toolkit. And so we're always trying to look at a population and say, like, the best individualized care for these people is when these providers are sitting in front of them, that they have resources that are going to be the resources that they need. But to really do that well, you have to have the prospective analytics. So I think we're coming along, but it's, we talked about before, looking in the rearview mirror, that we're starting to do that better, but we need to get on the front end of it to really start making a difference in value-based care.
Thank you. Rick, anything to add to that?
Yeah, a couple of thoughts. I mean, I think one of the things that we hear a lot from our customers, and that has come up in this panel today, it's the concept of identity management. To do the things that you all want to do with your patients, to coordinate care or your members, you need to know that Rick Rubin is not our Rubin, is not somebody else, for a lot of reasons. We all collectively spend a lot of time and are challenged in a lot of ways by the fact we don't do a great job on identity management. So one thing that we can do is to try and think about how we invest resources as a state, as a community, both on the provider side, who's providing care, and on the patient side, who is this person in front of us, so that it's easier for all the participants to be able to know, who is who, and what's been done to them. I think as we start to expand the continuum of health to include social determinants of health, that problem is only going to become more profound. And by the way, if we want to address equity, we're going to have to add to our knowledge of the identities, what are the meaningful characteristics, race, ethnicity, language, gender, and so on. So I think identity management is one. Two, as has already been mentioned, driving standards to a greater degree. The reason our cell phones exchange information a lot better than our EHRs is really because of the prevalence of standards. So I think, everyone should take a pledge not to buy proprietary tools, and to invest in the promulgation of standards. That's going to make it a lot easier. I think one other thing I'll just have to mention, if you go down the street and you watch people, they're all on their cell phones. They love their cell phones. They'd fight you if you tried to take their cell phones away. Marla, I'll bet very few of your providers would fight you if you took their EHRs away. In fact, they'd probably cheer and thank you for giving them their lives back. So we have inflicted mediocre technology on the people who we're all counting on to operate the system. It in many cases does not make their lives easier and better. And as Marla said, does not allow them, those systems are not always designed to really enhance the outcome for the patient. And so I think collectively, any society that has created something like, a smartphone, we can do better by the people who work in our system. We can do a much better job of providing them tools that helps them reclaim the joy of why they started in this care business, and allows them to operate more rather than less efficiently. So doing a better job on those applications is another thing we should all be thinking hard about.
Great. And you may feel, Rick, that you kind of just answered this, but I'm going to ask you this question anyway. If you had a magic wand to optimize the interoperability and value-based payment juncture, what would you wish for?
I think today, knowing where we're at with sort of the infrastructure that's out there, I would wish for that thing that I mentioned earlier. I would love to see the focus being on what we could do and should do, rather than all the things interoperability isn't, and all the things we haven't achieved. And then let's be very specific about what we want to achieve. I'd make the bet, that we have enough capability. We have incredibly smart and dedicated people. We've invested in this organizational infrastructure. We have folks at the state on both the healthcare and public health side who really want to do the right thing. I think if we had that kind of a conversation and picked one thing or two things or three things, I think that's where we would make a lot of progress.
Thank you. Marla? What would you wish?
I would say if I had a magic wand, I would make absolutely sure that all these conversations continued to be patient focused. I feel like that's everyone's intent in the beginning, but I feel like it's very easy to veer from that if you don't stay really solid in that focus. And I say that because I think if you're staying patient focused, most of us agree that value-based would move along a little bit more quickly. And I think if value-based care moves along more quickly, it will be necessary for enough people to enter the conversation and actually need this interoperability that it becomes more urgent. And then I think that's what's going to drive it to change faster. We have to have everybody needing the same end result. And to do good value-based care, you have to have the interoperability. So we need more people on board for the value-based care, which I think starts with everyone being patient-centered. And then I think the rest of it falls into line. I'm not saying easily, but I think if we stay with that focus, I don't think there's a whole lot to argue about in what direction that we have to go. So that would be my hope. And then, like I've said a few times, really moving it to, perspective analytics rather than looking in the rearview mirror. I mean, I love that I can efficiently get a gap list now, but when I look at that, a gap list is where I missed. I don't want to run a bunch of lists about where I missed. I don't want to miss. So I just hope we can really change that perspective over time.
Thank you. Sakshi, your magic wand.
So I think we're at important crossroads in healthcare currently. Interoperability has risen to the forefront. It has some potential promise to empower providers and payers with the information they need to implement value-based care models. Moving forward, the key will be to ensure that organizations have the right technology to quickly pivot as CMS interoperability rules come down, to continue the quality outcome movement towards value-based care. With that, if I did have a magic wand, I wish for a faxless future. A future one where we fully integrated and interoperable across our entire network. Our providers have the best information available to them at the point of care, allowing them to provide the best care to our members, one that optimizes health outcomes at affordable costs. There are no unnecessary, duplicated, redundant services being provided to our members. All of this with the goal to support healthier populations, great member and provider experience, and all of this running on a backbone of seamless flow of relevant contextualized information. So that is my wishful utopic version of the world if I did have a magic wand.
Thank you. So we have about 10 minutes left, and I'd like to bring Kathy and Vishal back and answer some of the questions that we have. Oh, my questions just went away. I know we have some in the chat too, but please, if you have more questions, drop them in the Q&A. We do have, when you say they have the infrastructure, when you say the infrastructure is evolved and matured, does that mean Premera hopes to acquire more data? So Sakshi.
So I think data acquisition is definitely one piece of the evolution and the maturation of the infrastructure, but then application of the data is the bigger piece, because I think the standards have made it easier for us to acquire data in a way that it can be now stitched together in that longitudinal health record, like I said. But then how do we query the data? And I think we've heard that theme across multiple speakers and presentations today, is the application of that data so that we're not only doing the retrospective analysis, but the prospective and the real-time analysis at the point of care. So I think it's a few different pieces when I speak to the evolution and the maturation.
Thank you.
Denise, I inadvertently, I was trying to help. I sent the questions that were there directly to Kathy and Vishal, but if you want me to read them, I can. There was one question for Kathy that said, these are both come from Dr. Doug Conrad at UW. Would you share some emerging, particularly promising examples of healthcare organizations supplying useful healthcare information to patients and producing improved results in patient care?
Thank you. Kathy, would you like to answer that?
Sure. I'm not sure I have any great examples. I think from an overall perspective, the use of data to actually look at healthy behaviors and grouping that in a way that, consumers can actually see that their behaviors are impacting their health is kind of one high level area. I think interoperability in the world of, wearables and some of those kinds of things really have the potential to impact the way that consumers interact with data as well. So those are two examples that kind of come to mind, but I'll give it some thought and give any additional examples as I think of them.
Thank you.
Could I speak to that briefly? Just, I think one area that, obviously we've seen during the pandemic, we saw a lot of uptake of telehealth. And, that has waxed and waned as the system opens up. But I think one particular area of telehealth, the use of telehealth services in the behavioral health area is very exciting. As a state, we focused a lot of energy in that area. I think we all recognize the importance of that space. And I think there are elements of how that technology is used that seems to work pretty well in certain types of behavioral healthcare. And it also can serve to extend a workforce that is way short of what we all need. So in terms of examples of how people are using technology on the industry side to assist consumers, I think there's some really exciting things that a variety of companies are doing in terms of using behavioral telehealth services to do a better job of meeting the needs of that population.
Thank you, Rick.
And the other question from Dr. Conrad was for Vishal. And it says, analogous to my prior question for Kathy Ott, are there a few data systems, can you give a promising example, with forward-looking designs that are producing improved patient care results now? Just an easy question.
Dr. Conrad, I think you know the answer to the question. I'll maybe try to answer it in a different way. When we talk about data and interoperability today in the healthcare space, so much of the dialogue that we have is less about interoperability. It's more about transparency and being just able to overcome the hurdles to get the data, right? Regulatory, policy, market, you name it, right? There are more efforts afoot now than there were maybe 5 years ago around the term data democratization. And I think over time, they will take us to the place where we're looking at more forward-looking designs as opposed to just trying to get the data in the hands of the people who want it. An example is, Rick used the example of everybody having a smartphone, right? Our healthcare system is largely transactional in nature today, right? It's episode-based, it's transaction-based. We document what happened, and that becomes the basis for what we think we need to do, right? But the documentation and the data is really about what happened, not what should happen or what should be about to happen, right? Except for maybe orders. Systems that use clinical orders, data about clinical orders is probably the only forward-looking thing that we have documented in the entire healthcare system today, the clinical care system today. How do we use it? It doesn't translate into anything right now. If I need to find what prescriptions were written, not which ones were filled, but what was written, it's a very difficult thing to accomplish unless I'm within the EHR and I can see all the orders. And even then, so I think it will take a mindset shift for us to be able to get to that point. We at least need to start talking about it.
Thank you. Marla, we have a question for you. So your community is headed toward capitation so much more than anyone else. They need complete patient information at the point of care. What is missing for your providers and patients right now that requires better interoperability?
Well,
how much time do we have left? No.
Yeah, 5 minutes. You can take the last 5 minutes, Marla.
In full disclosure, we are launching this whole thing we've been working on for a year on July the 6th. So there are probably gaps that I'm still not aware of, but we partnered with the Central Ohio Primary Care because they're already such a big presence in the system. So I feel confident that at the point of care, they will have information if some of the, on the 32,000 of these, there are about a third of them have already gone to COPC, the group we're working with. So we put things in place so they'll have information on them. Now, I'm going to be honest with you, I saw it was just kind of a representation video of it yesterday. It's still not easy. Like, we built it, but it's still not easy. You know, I mean, it's going to take a minute, the way it flows into the EMR from the data warehouse. I mean, it's just not user friendly, but I'm confident we'll have that information. That is why they're our capacity partner. That's why we partnered with them. Looking forward, there's another huge group in Columbus where it could easily be that they're still taking care of a third of that 32,000. So we're going to have to figure out a way to incentivize that group to work with us so that they will send things to our data warehouse so that we can pull from those, because we do a lot of proactive outreach on high and rising risk members. You don't even know who to outreach to if you don't have the analytics to look at where you can make the biggest difference. Who's ending up in the ER 5 times a year with migraines because they're not seeing a primary. Those are the things that we are really good at intervening on, but you can only be as good as the information that you have. So that's not a very succinct answer. I think we're probably going to be about 35% of the way when we launch, as far as how I'd like it to go. And it is it's not a new concept, but it's a pretty drastic step in that market. So we're going to be building it while we fly it, which we all know can be a challenge, but we're going to take it on. So.
Had myself on mute. We appreciate you doing that because we get to learn from you, right? we get to learn from your successes and your failures too. And so, or maybe I shouldn't say failures, but speed bumps that you.
I'll probably have much more of an opinion in a year. Let's put it that way.
Well, then we're bringing you back. Give us an update. So I'm going to invite Nick Locke to come in and close us out here. We thank everyone for all of our speakers today. It's been fabulous.
Yeah, thank you, Denise, and thank you to all of our speakers. I think everything that we're talking about today is definitely applicable to our work at the foundation, and I'm sure many of us in the audience have been in conversations about interoperability. I think not a day goes by where we don't have a conversation in a work group about ranging from pediatric asthma to social need, about how if only we had improved interoperability, we would be able to improve patient care. But I really appreciate everyone, all of our panelists, ranging from Jan Berger to our panelists, Vishal and Kathy from the Healthcare Authority, and Marla, Sakshi, and Rick sharing their experience and really reframing the conversation. I think there's a lot about how we can align across disparate stakeholders and especially align our motivations in order to come up with some common definitions and common goals. And it's once we get to those granular pieces and stop talking about interoperability as a huge topic, but really focus in on what we want to change, that we're going to be able to create some action steps and create some of that change. And I think it's really important just to think about improving the communication and improving the trust between all of these actors as we go through. So thank you again to everyone. Before we go, I would just like to highlight that there are still 2 more webinars in our Change in Action webinar series from the Foundation for Healthcare Quality and the Washington Health Alliance. We will be covering aligning quality measures later in July, reviewing what we learned from last year and talking about how we can create action through our quality measures. And then later in October, we will be discussing aligning payer strategies in order to improve population health. So thank you to everyone for being with us today as we went over interoperability, and I hope we will be able to see you again in July and October as well. Thank you to our panelists and thank you to our participants. I hope you have a wonderful rest of your day.